is Dr. Raghda AlMaashari, and I'd like to thank you all for your attendance. I know it's quite difficult actually to attend the last session, so truly appreciate it. Today, I'm going to be talking about skin manifestations of systemic disease. It's quite difficult actually to summarize this in a 20 minutes talk, so I'll try my best just to highlight a few disorders that could be actually encountered in the allergy clinic. So as we all know that the skin is actually the largest organ, and skin could be the mirror and the reflection of what's going in our body. And as we're aware that systemic diseases, they may have occult or even diverse clinical presentations, and that makes them or pose a diagnostic challenge. And since some cutaneous disorders, they can be the initial sign of internal disease, it's very important actually to recognize them. For better understanding, I've actually divided my talk into different categories. I'm going to be starting with a few cases, and accordingly, we're going to go and discuss a few highlighted disorders. So I'll start with the case that I've actually seen in the ER as a resident. Imagine going to the ER and seeing such a patient. This is a 46-year-old female admitted with a 2 weeks history of general fatigue, joint pain, and worsening rash. What's the first thing that should come on your mind when you see such a rash? So, of course, we had lots of diagnoses in our mind. However, this turned out to be lupus, systemic lupus erythematosus. So with regards to the cutaneous rheumatology, we have different disorders. This includes lupus erythematosus, dermatomyositis, Raynaud's phenomenon. I'm not going to go through the list just for the sake of time. However, with regards to cutaneous rheumatology, in this group of patients, we need to couple the complete cutaneous examination. We need to look at the hair, the nail. Lab evaluation is important, including also the clinical criteria of different disorders, clinical pathological correlation, because of course we need to take a biopsy for such patients in order to reach the final clinical diagnosis. With regards to lupus, yes, it is a multisystemic disorder that affects the skin. We have different types of lupus, which is the acute lupus. We have the chronic lupus, the subacute, where patients may present with psoriasiform type of lesions and even annular lesions. Also, not to forget the hypertrophic lupus tumidus, which can be actually misdiagnosed, especially that the patients may have a negative autoimmune workup, Chilblains, bullous eruptions of lupus, and also Rowell syndrome, which is lupus erythematosus along with erythema multiforme. What is the distribution of the lesion? You'll see most of them, my slides are adapted from Bologna. This is the book that we actually used as a resident, and it's the greatest source actually to refer back to. With regards to acute lupus, patients may have a butterfly rash, and it could be actually generalized. Subacute lupus, as I mentioned, it could be psoriasiform and annular. And we can see here the clinical pictures of the malar rash, the subacute lupus, and the discoid lupus. Always you need to look for follicular plugging. Sometimes patients may have vitelliginous-like changes. Always look at the ear because it is actually the clinical clue. Moving on to dermatomyositis, it's a disease of presumed autoimmune pathogenesis. Here, patients present with a symmetric proximal extensor inflammatory myopathy and characteristic cutaneous eruption. Keep in mind, not all patients with dermatomyositis will have myopathy because we have the amyopathic dermatomyositis. So that's why autoimmune workup in those patients is important. What are the most common cutaneous findings with dermatomyositis? As we can see here, the heliotrope sign, where patients present with violaceous patches around the eye. Also, we have the Gottram papules, where patients may have those lesions, mainly on the knuckle. If it is found on the elbows and on the knees, this is called Gottram sign. And not to forget, always check for the nail changes, especially the ragged cuticles, and look for the dilated nail fold telangiectasia, because this will aid with the diagnosis of dermatomyositis. Moving on to vasculitis. Vasculitis, which is the inflammation of the blood vessel wall. It's always important actually to categorize vasculitis. Is it just a skin-limited skin disease? Is it a primary cutaneous vasculitis with secondary systemic involvement? Or it is a cutaneous manifestation of a systemic vasculitis? And we can see, of course, the pedicular rash and even the purpuric rash. And in some cases, it could be severe. Of course, we should categorize vasculitis depending upon the caliber of the predominantly affected vessel. If it's a small, if it's going to be the cutaneous small vessel vasculitis, ranging either from the acute edema, acute hemorrhagic edema of infancy, also Henniction and purpura, which we actually see commonly, where we have patients may have the palpable purpura. Sometimes it looks with blisters. Of course, in such cases, you need to take 2 skin biopsies, which is the lesional and the perilesional, just to rule out if there is any IgA involvement, especially if a patient is an adult, because this could be related to underlying malignancy. And of course, the other calibers, whether it is the small and medium size, and the polyarthritis nodosa, and even the large vessel vasculitis. Moving on to Behçet's disease, which is a polysymptomatic disease with unpredictable exacerbation and remission. Yes, patients usually they do present with a recurrent history of genital and oral ulcers. We should not also forget that sometimes they may have ocular manifestation, which is the main cause of morbidity. The most common finding with the ocular manifestations may actually include the posterior uveitis. Also, patients may have anterior uveitis, not to forget the retinal vasculitis. And in most cases, it's actually painful and it may also lead to blindness. Patients with Behçet's may also have joint involvement, which is the arthritis, and they may also have abdominal pain that could be sometimes difficult to distinguish it from inflammatory bowel disease, and not to forget the neurological and the vascular aspect. And with regards to Behçet, yes, we do have a criteria which we actually follow, which is the International Study Group criteria. As I mentioned, most of the patients will complain of recurrent oral ulceration, recurring at least 3 times in a 12-month period, plus any of the 2, which includes the recurrent genital ulceration. We already mentioned about the eye changes, where the posterior uveitis is the most common one. With regards to the skin, patients may have erythema nodosum-like lesions, papulopustular lesions, and even acneiform lesions. And of course, with regards to pathology, as we can see it in the below picture, where patients may have a skin reaction that may have even after a needle prick. So this, we need to consider it. Okay. Rheumatoid arthritis. We've always seen rheumatoid arthritis, the classical findings of the swan neck deformity and also the ulnar deviation. And patients also, as we can see in the below picture, may have actually something which is called a bywater, which are lesions, which are purpuric lesions mainly seen on the digits with a type of vasculitis. Patients also may have rheumatoid nodule, rheumatoid papules. And as we can see here in the below picture is pseudoporphyria. Of course, those patients are in treatment. So sometimes the treatment also may cause cutaneous manifestations. So pseudoporphyria is mainly caused by different medications, but amongst them is NSAIDs. Another thing that I would like to highlight is also methotrexate, which can also cause accelerated nodulosis. In some cases, it could actually be missed. And we've actually published that in 2016 with regards to methotrexate-induced panniculitis in a patient with rheumatoid arthritis. Yes, it is uncommon. However, we need to keep that in mind. Okay, so that was actually rheumatology. Moving on to the next category. So I have a 47-year-old female. This patient, actually, I saw her in the ward. I was called as I was told that she was treated as a case of skin candida with no improvement. So something which I haven't mentioned, that this patient actually had a GI malignancy. Anything on mind? Okay. So this was cutaneous metastasis. Okay. So the next actually category is cutaneous hematology and oncology. So yes, metastatic disease, cutaneous T-cell lymphoma, leukemia, and vascular neoplasm, and not to forget the cutaneous reactions due to chemotherapeutic agents. I'm not going to go through this criteria. However, this is Kurth criteria. It has been proposed by Helen O. Kurth, and it's actually used to establish, to see if there is a given criterion. Is it because it was a chance, it has occurred at the same time, or is it due to malignancy-associated dermatosis? So we're going to be talking about a few paraneoplastic dermatoses, starting off with Basic syndrome. This is also known as acrokeratosis paraneoplastica, which is an acral psoriasiform plaques. Patients may have it actually either on the ear, the hills, and lesions sometimes could be violaceous, and it's associated with aerodigestive tract malignancy, such as the pharynx, larynx, and the esophagus. Next is the carcinoid syndrome. As we all know, patients have flushing and erythema of the head and the neck, and even pellagra-like dermatitis, and this is usually associated with mid-gut tumors. Okay. Very busy slide. However, I'm just going to be talking about erythema, gyraites, and rippins. This is a figure type of erythema, which is usually migratory. Patients will have a concentric type of erythematous lesions, often giving the appearance of a woody grain appearance. And usually the most common malignancy that's associated with erythema, gyraites, and rippins include lung malignancy. Another thing that we need to talk about is the sign of Lazare-Trelay. Us as dermatologists, we see many cases of seborrheic keratosis. However, usually patients do not have much complaint about it. If patients present with lesions that are actually with a rapid occurrence and they're complaining of weight loss, and sometimes if it's associated actually with itchiness and even acanthosis nigricans, yes, think about malignancy, especially GI malignancy. Okay. Next is acanthosis nigricans, which is a hyperpigmentation usually seen in the flexural areas, which is mostly commonly found on the neck, on the groin, and the axilla. However, if we see lip or labial mucosa involvement and even involvement of the palms, we need to consider that there could be an underlying malignancy. How should we evaluate patients with acanthosis nigricans? So it all depends upon the history. If the patient is complaining of a sudden onset of acanthosis nigricans with weight loss, yes, think about malignancy. If the patient is overweight or obese, this is what we commonly see, and that could be due either to diabetes mellitus or even to thyroid disorder. And if the patient is actually having Shirley's striae, hypertension, and Buffalo's hump, we need to think about Cushing syndrome. And not to forget, sometimes acanthosis nigricans could be caused by medications such as steroids and even protease inhibitors. And this another disorder that could be actually encountered in the allergy clinic, that patients were having acquired angioedema due to C1 esterase inhibitor dysfunction. And this could be actually associated to B-cell lymphoproliferative disorder and even monoclonal gammopathy of undetermined significance. With regards to dermatitis herpetiformis, this is actually a gluten type of cutaneous manifestations due to gluten sensitivity. Patients may present with pruritic erosions and even excoriated papules, usually on the extensor surfaces. And again, we need to do skin biopsy for those patients because sometimes dermatitis herpetiformis may be associated with T-cell lymphoma. Okay. And mycosis fungoides, we see this often, and sometimes it could be misdiagnosed as eczema. This is a patient that I've actually seen her, and it turned out that she's having the folliculotropic type of mycosis fungoides. In those patients, we need to rule out, of course, Sézary syndrome. And you can see that severe, cutaneous manifestations that she's having. In this case of this patient, she was actually diagnosed as a case of psoriasis, and she was treated even on biologics. However, when she came to me, we're like, no, we need to take 3 biopsies, and it turned out to be MF. And of course, with regards to Schindler syndrome, patients may have chronic urticaria, they can have fevers, arthralgia, and bone pain. Yes, this could be associated with a paraproteinemia, so we need to take that into consideration, especially when you're seeing patients with chronic urticaria and other symptoms of fever and bone pain. Busy slide, I'm not going to go through the familial cancer syndromes, but I included it here. And as I mentioned, with regards to cutaneous reactions to chemotherapeutic drugs, if I'm going to be talking about this needs another presentation, but we need to keep that into consideration, especially when we're being called to the ward to assess those patients. We need to be aware about the different manifestations or cutaneous manifestations of chemotherapeutic or biological targeted therapies. Category 3. So this is a very easy case. This is a 23-year-old female recently diagnosed with nephrotic syndrome and started on oral steroids, and she presented with this. Yeah, so yeah, this is striatus extensa. And yes, the other category we're going to be talking about is the cutaneous endocrinology and metabolic disease. What are the dermatological manifestations of diabetes, thyroid disease, Cushing syndrome, and Addison disease? With regard to diabetes, we already discussed about acanthosis nigricans. How about the diabetic bulla, where patients may present with tense non-inflammatory bulla on the lower extremities, and this is due to an unknown pathogenesis. Sometimes patients may also have the diabetic arthropathy, where the skin is actually thickened and there could be immobility. We have the sign, which is called the prayer sign, that the patients are not able actually to put their hands together, the palmar involvement. So as you can see in picture B, this is the patient after receiving treatment and is able actually to approximate the palmar surfaces of the hands and the fingers. And of course, here we have as well the brown atrophic macules and patches, which is the diabetic dermopathy. Yes, we can see it often, and sometimes patients can be diagnosed as post-inflammatory hyperpigmentation, but this has to do also with diabetes. And not to forget the eruptive xanthomas. When we're ever seeing xanthomas, we need to consider the different variants of xanthomas. We have the plain type of xanthomas and also the eruptive, the tendinous. And sometimes this either will signal that the patient is having an underlying hyperlipidemia or even may have an underlying malignancy as well. And moving on to necrobiosis lipoidica, patient may have yellow atrophic patches. Sometimes, most of the time, they're actually on the shins, and it could be associated with ulceration. And moving on to thyroid disease, as we know, with hyperthyroidism, patients will have more warm and moist skin. And of course, the most common finding that we see with the hyperthyroidism is a pretibial myxedema. Patients will have thickened or indurated skin on the shins. And in contrast to hyperthyroidism, the most common cutaneous findings that we can see is the acquired ichthyosis, and not to forget the increased incidence of vitiligo in those subset of patients. How about Cushing syndrome? Yes, patients may have rounded faces, they may have the moon faces and the buffalo hump. Patients are at a higher risk, of course, of having striae that we're seeing much common actually in our clinic. And patients are actually at a higher risk of having fungal disorders, and not to forget the steroid-induced acne, which is a very common side effect of being on steroids for so long. Addison's disease, I'm not going to talk through about this in detail, but patients may have hyperpigmentation that may appear at sites of trauma, the axilla, the palmar creases, and even in different mucous membranes and the hair. And the next category, this is a 32-year-old female, known case of inflammatory bowel disease, and were consulted for fever and this rash. Yes, so this is sweet syndrome. And this is the next category, which is the cutaneous gastroenterology. We're just going to be talking briefly about the cutaneous disorders of inflammatory bowel disease, peristomal skin disorders, cutaneous disorders associated with GI bleeding, and their dermatological aspect of liver disease. With regards to inflammatory bowel disorder, yes, those patients are at a higher risk of actually having erythema nodosum, urticaria, vasculitis, and we're just going to be talking in a while about pyoderma gangrenosum and even sweet syndrome. So with regards to pyoderma gangrenosum, this is a neutrophilic type of dermatosis. Usually the initial lesion, patients would have a pustule on an erythematous or violaceous base or an erythematous nodule. And the characteristic lesion is an ulcer with a necrotic undermined border and usually like a gunmetal type of border. And with regards to the associated illnesses, it may be associated to inflammatory bowel disease, to hematological malignancies. So we need to take that into consideration. Again, I'm not going to go through the clinical variants, but for our reference, there could be the vesiculobullous type, the pustular type, the superficial granulous pyoderma, and the pyostomatitis vegetans. And in order to make the diagnosis of pyoderma gangrenosum, there is a criteria, which we have the major criteria and the minor. Patients need to fulfill at least 2 of the major criteria and at least 2 minor criteria. With regards to the major criteria, there could be a rapid progression of painful necrotic cutaneous ulcer with an irregular violaceous undermined border. We need to rule out other causes of ulceration. And with regards to the minor criteria, there should be a history of suggestive of pathology. Patient may have an associated illness and the histopathological findings of neutrophilic dermatosis, and it could be with or without with or without vasculitis, and the treatment or the rapid response to corticosteroids. Sweet syndrome, again, this is another neutrophilic dermatosis. We have the major and the minor criteria. I'm not going to go through this into detail. And with regards to peristomal skin disease, yes, we have the contact dermatitis, which is the irritant and the allergic. This could be actually encountered in clinics, so we need to keep that in mind. And it could be due to the stoma bag or even the adhesive paste, and also those patients, of course, that could be candidates of actually undergoing patch testing. Okay, and even pyoderma gangrenosum. So again, another busy slide, cutaneous disorders associated with GI bleeding or hemorrhage. So patients may have hereditary hemorrhagic telangiectasia, which could be macular and papillary telangiectasia, as we can see here. The blue rubber bleb syndrome, there could be subcutaneous blue to purple venous malformation, and this also could be associated with GI bleeding. Crohn's disease, we already discussed the different types of findings with Crohn's disease. And with Kaposi sarcoma, of course, those patients may have violaceous macules and papules, and there could be actually not only GI involvement, but also lung involvement in those cases. And the last one, which is a dermatological aspect of liver disease, with hepatitis B and C, patients are actually much more at risk of having vasculitis, arterial vasculitis, where patients would have arterial type of lesions, which last more than 24 hours, healing actually with the purpuric or post-inflammatory hyperpigmentation, and usually the lesions are painful. Lichen planus could also be seen with those patients, and also necrolytic acral erythema. Last category, which is the renal disease. Again, those are the genetic manifestations genetic disorders that could be associated with renal disease. We already spoke about lupus, and we already discussed hemocyanin purpura and the cutaneous small vasculitis. With regards to sarcoidosis, patients may have papules, nodules, or plaque. Don't forget the different types of syndromes that could be associated with sarcoidosis. And yes, those patients at a high risk of having hypercalciuria with regards to the renal disease. And the most important thing that we actually do see in our clinical practice as well is the cutaneous signs that we can see with renal disease. So we have here perforating dermatosis, and also we have as well patients having calciphylaxis, which is the vascular calcification, which could be actually painful. And also patients may have cutaneous disorders associated with long-term immunosuppression. So screening those patients is very important on annual basis, because they may develop actually at risk of developing squamous cell carcinoma and also Kaposi sarcoma. Pulmonary disease, again, we discussed about sarcoidosis, we discussed about dermatomyositis, and also arterial vasculitis. We already discussed about Kaposi sarcoma and how it could not only affect the GI, but as well as the lung. And with regards to pulmonary disease and infectious disorder, I just decided to discuss about varicella. So especially those patients who are having varicella and pulmonary involvement, this correlates with the severity of the disease. And of course, in those patients, you need to consider giving them the antiviral, especially if the patient is pregnant, if it's an adult, if the patient is immunosuppressed. And the last thing, which is the cardiocutaneous abnormalities, I'm not going to go through this. However, the only thing that I wanted to highlight, which is neonatal lupus, yes, those patients may have heart block, so first-degree heart block. So this is one of the babies that I've seen actually in my clinic a long time ago. So this needs to be taken in consideration. And of course, psoriasis, those patients are at a higher risk of having metabolic disorder. So those patients need to be screened for that. So I've gone through the different cutaneous manifestation categories. In summary, systemic diseases, they do influence multiple organs, and they often pose a diagnostic challenge due to their occult and diverse clinical presentation, especially that cutaneous findings can be typically the first and the most obvious sign. Therefore, it's very important actually to recognize such manifestations and allow for earlier detection and treatment while avoiding potentially life-threatening complications. With that, I end my presentation. Thank you very much for listening.